Hello, everyone. Welcome to our rounds on January 22nd. Today, we are very fortunate. We have Justine St. Laurent. She's a nurse practitioner from the North Bay Parry Sound Public Health Unit. She has been working there for the past 5 years in the NP role, doing the sexual health department. Her clinical background includes work in STI case management and women's health, offering education, prevention, and patient-centered care. We also have Lauren Eels. She's an RN with her BSCN MPH. She also is with the North Bay Parry Sound District Health Unit in the Sexual Health and Harm Reduction Program. She focuses on surveillance and monitoring of reportable sexually transmitted and bloodborne infections, STI case and contact management, and providing nursing services within the sexual health clinic. You're all welcome to put your questions in the chat, and we'll have questions and answers at the end. Welcome, everyone.
All right. Thank you so much, Kathy. Thank you, everyone, for being here and for having us today. We are going to jump right in because we have a lot of content that we're excited to share with you today. So just first, quickly, neither of us have any relationships with any profit or not-for-profit organizations to disclose, and our session has not received any financial or in-kind support. Our learning objectives for today, which were shared previously, we plan to cover some high-level overviews of the regional trends of reportable STIs in the region, specifically focusing on chlamydia, gonorrhea, syphilis, and HIV. And then we'll be reviewing some relevant clinical updates to guidelines specific to gonorrhea, syphilis, and HIV, including some testing and treatment recommendations and some key preventative strategies. As Kathy mentioned, we will do Q&A at the end, so feel free to type your questions in at any point during the presentation, and then we will review them towards the end of the presentation. Okay, so we're just going to start with a quick poll. You should see it pop up on your screen here. We just wanted to learn a little bit more about who is joining us today. If you can just select your primary practice setting, that would be great.
Set to 100%.
Okay. Yeah, you can come there. So we've got a few answers all from primary care. That's great. Okay. Okay, so we're going to jump right in here, starting with some of the trends that we see with chlamydia in the health unit region and in Ontario. So the chart that you see on the screen here shows the annual crude rates of chlamydia. In the red line there, we have the year-to-year rates for the public health unit, and in the purple, we have the Ontario rate. Chlamydia continues to be the most common reportable STI that's managed by the health unit in the sexual health clinic, with the rate of around 185 per 100,000 persons in the health unit region in 2024. You can see that the rate of chlamydia, both in the health unit and Ontario region, dropped quite substantially in 2020, timed with pandemic restrictions, likely reflecting a combination of changes in behavior and healthcare access. We did see also during this time a quite expected drop in testing volume that occurred. So looking at those numbers from 2019 to 2020, the total number of tests of chlamydia dropped by about 33% from 2019 to 2020. And this volume has fluctuated from year to year since then, but in 2024, we're still remaining at 27% below the testing volume that we were in 2019. So that lower rate that's continued could be partially reflected by decreases in testing. Throughout the presentation, we've sort of ended our reporting on our annual reporting at 2024. Just the 2025 data goes through a data cleaning process that's still underway, so it might continue to fluctuate a little bit into 2026. But for chlamydia, the preliminary data is showing that it's continued on a downward trend in our region for 2024. here we have a table that's showing the age and sex-specific rates averaged for 2020 to 2024. So what you can see here in the left side in blue is that females aged 20 to 24 and 15 to 19 experience the highest rate of chlamydia during this time. So typically we do see about 60% of cases each year among females. And that rate that's showing there for the 20 to 24 year age group was about 1,786 infections per 100,000 people. So just thinking back to the overall rate, which was around 185 per 100,000, if you think of all ages together. So we really do see quite a bit of concentrating in these particular age groups. Okay, we are going to move on here to gonorrhea. So that same chart again with the annual crude rates with public health unit compared to provincial. Gonorrhea rates in the health unit region do also continue to remain below the pre-pandemic levels, but that is despite increased rates in the province. So in 2024, in the health unit region, we saw approximately 21 infections per 100,000 people, and that compares to closer to 85 infections per 100,000 when looking at the province overall. The preliminary 2025 data does suggest a similar rate from 2024 to 2025. And then similar to chlamydia, the testing volume does also remain low compared to pre-pandemic testing in our region. So that drop from 2019 to 2020 in testing volume was about 32%. And by 2024, we still remained at about 24% compared below the 2019 volume. And here again, the age and sex specific rates here. So a little bit different from what we see in chlamydia. Annually, we do see about 55 to 60% of these infections identified among males. And it does vary a little bit more from year to year with gonorrhea, where we kind of see the distribution. So here we are still seeing this averaged over 2020 to 2024, with males 25 to 29 being the most represented here. In 2024 specifically, 67% of cases were among males. And in 2025, we actually did see males 35 to 39 being the most impacted age group, and also seeing higher than average number of cases among even older age groups from 40 to 65. So just highlighting the importance of continuing to test sexually active individuals across all age groups. Okay.
We have a question, yes. So just gonna launch the poll.
Okay, so if you can respond here, just what is the current recommended treatment for uncomplicated gonococcal infections? I'll give you a minute there.
Answers are coming in. Everybody seems to be answering right. Yeah. Just end the poll. Perfect. And share results. Okay, so yes, so a few people answered right. So it's the ceftriaxone 500 milligrams IM in a single dose in the new guidelines. So are we, yeah, you're on slide 11. So the National Advisory Committee on STBBIs released the interim guidance in early 2025 for the treatment of uncomplicated gonococcal infections, while the complete guidelines are still under review. The current recommendations is for ceftriaxone 500 IM in a single dose for all uncomplicated infections. And they also recommend test of cure at all body sites that tested positive for gonorrhea. The treatment recommendations have been updated to address the growing antimicrobial resistance in gonorrhea, both national and international surveillance efforts have shown increased resistance worldwide to multiple classes of antibiotics for gonorrhea. Trends in antimicrobial resistance have also shown a progressive decrease in susceptibility to cephalosporins and the identification of high-level ceftriaxone resistance, so predicting a potential for untreatable gonorrhea in the near future. This highlights the importance of ensuring recommended treatment approaches are used as much as possible, and the use of test of cure to ensure treatment success, and the use of culture as appropriate in addition to NAT testing to test for antibiotic susceptibilities. For example, in our practice, we do, if a client shows up with symptoms of discharge and you're testing at the urethral site or at the you're doing a pelvic exam, we do add a culture. Alternative treatment recommendations are currently under review and should only be used in specific instances. We can refer to the PHAC gonorrhea guide for alternative treatment. So this slide just kind of shows the importance of testing at all sites. So it highlights the potential for missed infections and onward transmission if only urine or other genital swabs were collected. So as shown above, the guidelines now recommend collecting these samples in most population with a history of sexual exposure at these locations. So not just certain populations, but your sexually active population. So test kits for these swabs are available to order from Public Health Ontario and have been approved for clients actually for self-collection in clinical settings. Complete recommendations for testing, treatment, and follow-up are available in the STI BBI guidelines.
All right. So we are going to transition and move on to syphilis. So here you see that familiar chart again with the annual crude rate with health unit region and Ontario. For syphilis, we've included all stages of syphilis infection here with the exception of congenital syphilis in this table. So you can see that the rate of syphilis in Ontario has been steadily increasing over the last decade. This is probably not news, and this has been happening across Canada, North America, and other countries as well. In the health unit region, we began to see a significant increase in 2019, which unlike chlamydia and gonorrhea did not decline with the pandemic restrictions in 2020. The rate in the health unit region did drop a bit in 2022, but then continued on an upward trend for the next 2 years. So in 2024, the rate in our region was about 12 infections per 100,000 people. The health unit and provincial rates do appear to have declined slightly in 2025, but again, based on just preliminary data that may fluctuate early into 2026. And we did also look at testing volumes for syphilis. So the testing volume in our region did increase quite substantially from 2020 to 2021 by about 54%, and then had a further 6% increase in 2022. So that may have been driven by increased awareness of syphilis that was going out through various local, provincial, and federal awareness campaigns.
Are we on my slide? Yes. Okay. So here we're looking at some statistics, Ontario statistics for syphilis. So just to kind of show that we've started getting more cases in female cases in the last 6 years. So it's showing here a steady increase in infections amongst female. So the female cases rose from 3.8% back in 2014 to 18% in 2023. And then in 2023, 8.5% of the female cases were pregnant. So this brings on the subject of testing during pregnancy. And here, I'm just going to give you some statistics for our health unit region. There was also an increase in female cases, and 46% of cases in 2023 were females. And there's been one case of confirmed congenital syphilis identified in our health unit region since this increase. And multiple syphilis infections have also been identified in women in our health unit region, but who were thankfully treated during pregnancy with the appropriate treatment before delivery. The health unit have also observed an increase, just as a side note, an increase in neurosyphilis alongside the overall rise in syphilis. These actually accounted for approximately 14% of infections in the health unit region between 2019 and 2024, compared to no confirmed neurosyphilis cases between 2010 and 2018. And as well, just to share with healthcare providers, we've also seen some otosyphilis causing hearing loss and tinnitus, as well as ocular syphilis causing uveitis and retinitis. And if you look at the STI treatment guidelines, the treatment for otosyphilis or ocular syphilis is the same as neurosyphilis. So an IV treatment. Moving on to the Canadian STI guidelines. So these are recommendations for testing during pregnancy as per the guidelines. So they recommend the first testing at your first prenatal visit, ideally in the first trimester, and then repeat screening at 28 to 32 weeks and at delivery if you're in a region where there's an outbreak area, or if your patient has ongoing risk of infection or reinfection. Additionally, the STI guidelines say more frequent screening for those at high risk and to screen all women who deliver a stillborn infant after 20 weeks of gestation. And again, with the guidelines, they're saying, this is our recommendation here from Dr. Carol Zimbalati for our district. She published a public health bulletin back in April of 2025, strongly recommending universal screening at 3 different points during the pregnancy until further notice, because we've had a rise in syphilis. So this is for all women, and this guidance remains active today. So, as for diagnosing, staging, and treating for syphilis, as it's a bit more complicated than for other STIs, our health unit, we do have a guidance document that we have on our website. If you look under healthcare provider resources for healthcare providers, so it's called the Management of Syphilis Infections, and this document is available on our website, like I said. So it does include guidance for looking at your test results, the recommended treatment protocols, as well as the follow-up serology procedures. And we're just going to show a slide that shows what the document looks like. It's a 3-pager document, pretty easy to follow. And there's also, this is from PHAC, but it's available on their website. They've published some resources for healthcare providers, and it includes this simplified algorithm for staging and treatment of syphilis. So now we're just going to go over a quick case study, a case pretty similar to what we see in our clinics, because we have one in Parry Sound too. So a case of a 39-year-old male with no past history of sexually transmitted infections. He was not on PrEP, married for 7 years to a male partner. He had one new partner, a male partner, met through Grindr, anonymous. So he had unprotected oral and anal receptive sex, and he noted a full body rash about 1 month following this exposure. He presented to the sexual health clinic for STI BBI testing about 1 week after this rash appeared. And he had no known allergies, was not taking any medication. And then his syphilis result was received as this, so reactive syphilis antibody, reactive syphilis RPR at 1/32, and all of his other STI BBI results were negative. And he, thankfully, for staging, had a previous negative syphilis serology done about 6 months earlier. So just for, if people want to use the chat box for staging, any guesses on where he would be? Just going to see if the chat is getting any guesses. Oh, there you go. Yes, oh, and so secondary, so the rash and then the fact that he had a previous negative result was helping too. But yes, so secondary, he was diagnosed as secondary syphilis, and he was treated with Pen-G IM in one dose, so 2 syringes. To get the 2.4, each syringe has 1.2 million units of Pen-G. So as repeat syphilis serology was recommended it's in our guidance document too, but the STI guidelines recommend repeat testing at 3 months, 6 months, and 12 months post treatment, which is what happened with him. And the contact tracing went back for 6 months. They do tell you in the STI guidelines how far to go back for contact tracing depending on where they're staged at. The patient was actually feeling a lot better even the next day after his Pen-G, almost back to normal, and his rash slowly went away. And then he had his repeat blood work done 3 months after his treatment, and the RPR had decreased to 1/8. The STI guidelines and the document that we have on our website, it's helpful because they tell you what to expect in this follow-up serology. Now we're going to change the subject a little bit and talk about some prevention for bacterial STIs. And it's promoted a lot when we talk about syphilis. So it's the doxycycline post-exposure prophylaxis, or DoxyPEP. So it's a new strategy that they came out with to prevent bacterial STIs. It involves giving doxycycline as post-exposure prophylaxis, and the research actually shows that this intervention can prevent chlamydia and syphilis infections by up to 70%, and gonorrhea infections by 33 to 50%. DoxyPEP is an appropriate intervention for gay, bisexual, and other men who have sex with men, or as we sometimes refer as GBMSM. And just to note that this is an off-label indication for doxy. So now we're just going to look at recommendations that they have on the National Advisory Committee on STI BBI. So what they have here is recommendation number 1 is their regime for doxy is 200 milligrams orally taken within 72 hours after sexual exposure, and they do say ideally within 24 hours. So to be offered to cisgender, GBMSM, and transgender women at increased risk of bacterial STIs as a component of comprehensive STI BBI services to reduce the risk of syphilis, chlamydia, and possibly gonorrhea. And then their recommendation number 2 is to discuss personal, community, and population level risks of antimicrobial resistance with individuals considering this intervention. And they do have in the document, it reviews the evidence as to how they came up with these recommendations.
Okay, thank you, Justine. All right, so I mentioned we have a lot of content to cover today, so we're going to shift topics again and move into HIV specific information here. So again, we have our annual crude rate in the health unit region and Ontario. And you can see here that the health unit region has had generally a consistently lower rate of new HIV infections than the province, with the exception of 2020. And these rates here reflect the year in which individuals were diagnosed with HIV, though we know that infection may have in fact occurred years earlier potentially. I would just make a note to interpret the provincial rates specifically here with some caution. These are based on reported new infections through the reportable disease system. However, the Ontario HIV Epidemiology and Surveillance System did perform a review of the 2023 data following seeing this kind of big increase here on the chart, and noted that there in 23% of the reported infections in that year, there was other lab evidence that suggested that they were not in fact new diagnoses. So they only looked at 2023, but possibility that that could impact previous years as well. And in our data for the health unit region here, we do remove cases if we do have evidence of it being previously diagnosed, so that we're just looking at new diagnoses here. For 2025, in our health unit region, we did not have any new cases identified. Now, we wanted to specifically highlight some information that is specific to the Parry Sound area, as we have seen a greater than expected number of HIV diagnoses in the region there. So here we have a chart that is showing the proportion of new infections in the health unit region from 2010 to 2017 on the left bar there, and then in 2018 to 24 on the right. So the green sections are showing the proportion of cases that were specifically in the Parry Sound region, and then the blue representing cases from the rest of the health unit region. So first, you can just see over the two time periods, the difference in height in the bars shows that the overall number of cases did increase, and that increase was about 33% during those time frames. And then specifically in the Parry Sound area, in the earlier time period, we saw 39% of cases overall, but that increased to 63% of cases in the second time period. So we did perform some in-depth review of the data around this for the Parry Sound area and found that the cases exceeded thresholds for greater than expected in years of 2018, 2019, 2020, and then again in 2024. And looking back, we did see this exceeding thresholds in 2011 during the first period as well. And so that threshold, just for your awareness, means that the case counts in those years were more than 2 standard deviations above a 5-year average for that year. When we looked further into cases in the Parry Sound region, particularly in 2018 to 2024, we were seeing some specific populations being disproportionately represented. So these factors are not necessarily common to all individuals who were newly diagnosed in the region, but we did see certainly some trends. So affecting individuals who use substances, including injection substance use, were currently experiencing or had recently experienced underhousing or homelessness, and particularly who reported sex with opposite sex partners. And then we did also see individuals with Indigenous affiliation being disproportionately represented. We did find as well during review of case follow-up that a number of diagnoses made during this time were being made at late stages of illness and also among individuals who had no previous HIV testing history. So that kind of highlighting a need to increase awareness of and access to timely HIV testing services. Now, another key piece we want to highlight here is that during these recent timeframes where we were seeing increases in HIV in the area, there were also noted co-occurrences of clustered cases of invasive group A strep infections that did share some common risk factors here of injection substance use, poor housing conditions, and these did come alongside community reports of significant skin wounds among individuals who were using substances. And some of this information had been sent out as well for public health bulletins of increased eye gas. So although we did not note any new HIV diagnoses in 2025, the ongoing eye gas activity among similar affected populations does tell us that there is potential for ongoing HIV transmission as well. Important factors to be aware of would be like similar transmission routes of both infections through sharing of injection substance use equipment, the potential for substance use to lead to skin breakdown or skin wounds that can create a portal of entry for the strep bacteria. Impacts of HIV, if present, on the immune system that can increase the likelihood that strep infections can become invasive. and then barriers affecting these populations to accessing medical care, including wound care, access to safe housing, harm reduction supplies, and HIV or other BBI testing and treatment services. So just kind of highlighting the value and importance of integrating these various aspects into care when working with clients from these affected populations. Okay, now here on the slide, we have some information that would be included in a comprehensive approach to HIV prevention. And so we don't have time today to unpack everything on the slide here, but did want to pause briefly on the first pillar there to acknowledge its importance and just encourage participants to hold these factors in mind when we move through the next slides, which are more focused on the clinical aspects of prevention. So just to note that without addressing social and system level factors, even the most effective clinical tools will have limited reach. So this can include stigma and discrimination, distrust in the healthcare system, having access to culturally safe and appropriate care, histories of personal or intergenerational trauma, being factors that consistently create barriers for HIV priority populations. So reflecting on our own individual roles and on how our organizations can adapt to address some of these barriers is foundational to increasing the uptake of testing, PrEP, treatment, or other related supports such as harm reduction or addiction treatment services. Okay, now moving into some of the clinical updates that we wanted to share around HIV. So in 2023, Ontario did release updated HIV testing guidelines for providers. So included here on the screen, don't expect you to be able to see all of that in detail, but it does include an algorithm that can be printed or made available for a quick reference tool. So we're not going to cover all of the details in there, but wanted you to be aware that this exists and it's meant to support decision making about HIV testing in practice. One of the key updates to highlight with this new release was the change in the window period for lab-based HIV testing. So it's now 6 weeks from exposure rather than 3 months, which was previously the guidance in previous guidelines. And as you see here in the 4 colors that are on the algorithm, it outlines a 4-pronged approach to testing. So identifying acute or recent infections, identifying chronic infections through indicator conditions, offering testing to members of populations with higher prevalence of HIV, and then finally testing in more specific care contexts, such as pregnancy or prior to immunosuppressive therapy.
Thank you, Lauren. And still on the subject of HIV, and Lauren mentioned it a while ago that one of the prevention strategies is the HIV PrEP. So as you see here, PrEP can reduce the risk of getting HIV from sex by about 99% when it's taken as prescribed. Multiple safe and effective PrEP, and there's also PEP regimens in the guidelines are now available in Canada, making it increasingly possible to find suitable options for all who could benefit from HIV PrEP. There is so tenofovir emtricitabine is the only approved PrEP product currently available in a generic formulation in Canada, making it the most affordable. So we had guidelines that came out in 2019 and they've updated them in 2025. The new guidelines came out mostly as new PrEP options became available, but also the previous eligibility rules were missing some people at risk. So it's a bit more open as to who we should be offering PrEP to. Clinicians are encouraged to assess HIV risk during routine health visits to identify who would benefit from HIV PrEP. And we're just going to move on to this table. It's a table that's in the Canadian guidelines, and it's just very helpful because it includes a clear, simplified table that that outlines the recommended test and clinical assessment to be done at baseline before you start your patient on PrEP, 30 days after starting them on PrEP, and approximately 3 to 4 months after. It's easy to follow.
Okay. And then here we just wanted to highlight the availability of online HIV PrEP providers, where access has really expanded in recent years. So online providers will provide most of these services or all of them virtually. They do support clients who have financial barriers to accessing PrEP if it's not covered through insurance. So the majority of people who access these will get their PrEP fully or almost fully covered. And these providers do also offer DoxyPEP, which Justin was reviewing earlier, to any of the clients who are interested and also eligible. And then, of course, they do follow all of the guidelines for ordering the regular blood work and comprehensive STBBI testing that's recommended every 3 months.
On the subject of DoxyPEP, I forgot to mention we don't have guidelines available right now in Canada, although we have those recommendations from the National Advisory Committee, but the CDC they have official guidelines that you can follow for DoxyPEP. Are you on the Mpox slide? Yes. So Mpox, as we know, it's still around. So in July of 2022 is when the WHO declared this outbreak, the outbreak of Mpox, as a public health emergency of international concern. As we know, most patients diagnosed with Mpox reported high-risk sexual behavior. So either sex with multiple partners or as a potential risk factor. And we're not going to go into the clinical side of Mpox and the clinical features, but just wanted to point out that as for prevention, the Immune vaccine, which had a big uptake back in 2022, thankfully for the population at risk, it's offered here at the health unit and in Parry Sound as well. I believe we do have to send it to Parry. It's a frozen vaccine, so it has to be sent to the Parry Sound office, but is available at no cost if you have a patient that requires this vaccine. Right now, I think it's offered in our clinic anyways to all GB-MSM population.
Okay. And of course, we wanted to let you know about some of the health unit services and supports that are available, both to clients in the community and to healthcare providers. So we are able to provide free STI medication delivery to healthcare provider offices for use of the most common recommended treatments, so particularly azithromycin, ceftriaxone, and also the long-acting penicillin recommended for syphilis treatment. If interested in that, people are welcome to reach out to us and we can talk about how to make those arrangements. We do provide quite a bit of information for healthcare providers on our health unit website, including providing some basic trends and information on what we're seeing for infection rates. We do still offer our sexual health clinic services, as Justin has been mentioning throughout the presentation. So we have a clinic still operating in Parry Sound as well as North Bay, and occasionally offering as well to other outlying areas. So this provides STBBI prevention, testing, and treatment, along with contraception services. And we have been narrowing our scope a little bit to really focus on clients who don't have access to a healthcare provider, but while still offering services to priority populations. Then we do still perform case and contact management for reportable infections and can provide support to healthcare providers as needed for follow-up and connection with clients. Immunizations, as Justin mentioned, so beyond just Mpox, there are other immunizations available for infections that can be sexually transmitted, and there are some criteria to allow people who are at risk for these infections to get the vaccines at no cost. We are signed on as a designated getakit.ca treatment partner. I'm going to go through that in more detail in the next slide. We are also the core distribution site for the needle and syringe program and the Ontario naloxone program, meaning that we can make arrangements for other um, offices, community service providers, or healthcare providers to be able to distribute these supplies. So we do provide them at our own sites, but we also would be the place to connect with if offices were looking to be able to distribute supplies from their own locations. So again, if that's of interest, please reach out to us and we would give you more information on eligibility and the onboarding process for that. And then, of course, we always have ongoing population health assessment and surveillance activities. So keeping an eye out for changes in trends, new clusters, things like that, that we would need to inform healthcare providers or the community about. Okay, and so yeah, we just wanted to provide a little bit of detail here about what getakit.ca is. People might be familiar with this already, but Getakit started as a program that offered HIV self-test kits to anybody living in Ontario. They would mail them to people's homes. They've expanded quite a bit since then. So we signed on as a treatment partner with Getakit at the beginning of 2024, which allowed for anyone with an address in our health unit region to have access to more comprehensive STBBI testing through this program. And then if any positive results come in, the nurses at the sexual health clinic would provide follow-up and treatment for that. So this is available to anyone who's 17 years of age or older, has some form of insurance, OHIP or other private health insurance, and has an address, like I said, in our region that's based on postal code. Although it is really expanding across the province to other health units as well. So quite a few other health units are also providing this. And basically a client would just have to have access to internet and be willing to go to a lab for testing. So some unique features are clients go online, create a private and secure account where they complete a screening questionnaire that then uses an algorithm to recommend appropriate tests based on what they enter for their demographic and exposure history. These recommendations are all in line with what we've reviewed and what the Ontario, Canadian, and Canadian STI screening recommendations are. If they accept the recommended testing, then requisitions would be sent directly to a lab of their choice, and often clients are able to access testing the same day that they go on to create their account and get results back within a few days. The HIV self-testing kits, and now also self-collection kits for pharyngeal or rectal swabs for chlamydia and gonorrhea can be mailed directly to clients' homes so that the swab kits can be collected by the client and then dropped off at a lab. And then they have also expanded to make a connection with Freddie or GoFreddy, which is one of the online HIV PrEP providers we were talking about. So when clients complete their screening questionnaire, if their answers suggest that they would be appropriate PrEP, they would have eligibility for PrEP, then the program will offer them a direct referral to Freddie, which they can choose to accept or just look up further information on their own. So some of the recent data that's come out from this is that it's that PrEP referral process has been quite successful, and particularly in our health unit region, there seems to be quite an appetite for it and a good uptake of that referral. So it's been quite successful so far and is, like we said, eligible to anyone in the health unit region. Okay, that actually brings us to the end of our planned content for you today, which was a lot. Any of the resources or the guidelines that we were referring to are linked here at the end of the document. But if anyone wants anything specifically sent to them, we're happy to do that. And yeah, and we do have time left for any questions that anyone might have.
Feel free to ask, unmute yourself and ask live, or you can ask in the chat if you have any questions.
Perhaps you could include your contact information if people want to reach out to you directly in the chat.
Okay. Oh, yeah, sure. we moved through things a little bit quickly and from topic to topic a little bit. So if anyone wanted us to kind of go back or put any slides back up on the screen just for to have a little bit longer to look at them, we're happy to do that too.
I was writing yours too, but I'll let you. You're
Okay.
putting it in.
Are you okay if I share the slides if they wish to have them, or?
For
Yes.
sure.
Yeah.
Not seeing anyone raising their hands. Either everyone's really shy today or you covered the material well. All right. Well, seeing that there's no questions, thank you very much, ladies, for coming and presenting to our team today. That was fantastic. I know I learned a lot. I didn't know a lot about treatment, so this has been fantastic for myself. And just the heads up that our next set of rounds will be February 26th, and it should be our pharmacy team here at West Prairie Sound presenting. So thank you once again, and I look forward to connecting with you again in the future.
Thanks,
All
Kathy,
right.
for organizing it.
Yeah, thank you so much. Thanks everyone for attending.